Basically, if you look at the urbanization, that how much population is living in rural areas. So if you see this graph, this is basically data for the last 10 years. If you see that there is no much change in this data, what does that mean? That not many people are, shifting towards the cities in Pakistan particularly, and urbanization is not very high in Pakistan. If you see and compare it with the India, the population in, according to the census of 2017, living in rural area is 65%, which is less than the Indian, which is 68%. The reason of that low is because the most of the people, when they came during migration, they settled in the cities. But this is, and then another reason is the different definition for urbanization in two countries. So because of that is going to be happen. And there are different, specific issues to the rural areas. There is low access to the basic human needs, for example, drinking water, sanitation, education, quality health, public transport, poverty, and geographic isolation, poor infrastructure, and all these things are basically included in the Agenda 2030 of UNO. And all those deficiencies which have been pointed out this agenda are basically the problem of the rural area. And the prevalence of common mental disorder, according to the WHO, this is a figure you see, and according to WHO, this data of higher Pakistan than the other developing countries with the similar socio-economic restraints. So even in the, look at that background, this data of psychiatric prevalence is very high. And if you look at the rural area, that is much higher than the urban areas. So, but these studies, although this is published, this is, I have copied from this website of the WHO, but these studies have been questioned in one of the articles that was published in British Journal of Psychiatry in 2005, and this article raised the issue that the evidence is questionable because of the methodological flaws in these studies, and they suggest to exercise caution in generating data. And after that, if on the other hand you look at the scenario of the mental health in Pakistan, that according to the Human Rights Commission report of the 2018, no proper mental health policy exists in Pakistan. There is a lack of political will to invest in mental health, and mental health is not accessible to more than 80% of the people in Pakistan, according to the Human Rights Commission report of 2022. And human rights of mentally ill are jeopardized continuously, and economic burden of mental illness is estimated to be 6.2 million, and there is a paucity of local research. And this research basically, what we need that to address all these issues, we need a proper data. Why we need proper data? So the stakeholders can be convinced for designing policy and allocation. So for that we adopted this survey, and this is basically, instead of gathering the data from the hospital, we adopted the strategy of doing the survey in the community, because the hospital population is cannot be generalized on community, because only severe cases are coming to the hospital. Second thing, the common illness, minor illness, they are more prevalent in the society, and many of the physicians are unable to diagnose because they are presented in a disguised form, and people are not trained to identify them. That's why we need a community-based survey for a proper prevalence of these disorders. So what we did that we started this survey, and to start this survey we take permission from the National Bioethics Committee. After that we contacted Pakistan Bureau of Statistics, who provided us basically the sample calculation and identified the areas to be where we can conduct the study. And this is basically the sample population that was identified. And basically we have an option, because we don't have psychiatrists, so the problem there, who is going to conduct the interview? So what we adopted, that we adopted the standardized assessment tool layman, these are called layman tool. Layman means that for these tools, you doesn't need an expert psychologist or psychiatrist. Even any graduate can apply this tool after some training. So there are many tools are available, even in a developed countries. So in Pakistan, we basically selected the mini tool. And this mini tool was the reason of selection because this was provided to us by Sir David Sheehan, free of cost, although it is on cost, but when we requested him that we are going to conduct it in Pakistan, we don't have funds, so we've been given permission to use it free of cost. In Dow University, we translated that interview. This is a 45-page interview for the one patient in Urdu, and that was conducted. And we have shared this, all this process continuously. You look at that in all the conferences and improving this survey with the critics and coming from the different colleagues. And now I'm going to share just the data because data has not been finalized. It is in the process of analysis. And this is the data most recent which I received yesterday night. And according to that data, we approached 20,833 households all over the country. Eligible participants were 17,957 and 17,773 participants completed the interview and the response rate was 85%. The reason for non-response was locked house, non-residential buildings, no adult above 18 present in the house, Mohalla residency security didn't allow the team to conduct that survey in that area, and refusal, even many a time the refusal was at the door, and so many things because of this interview cannot be conducted in certain places. The total sample of this survey, which was conducted from 2019 to 2022, from the sample basically calculated by Pakistan Bureau of Statistics, is basically this one you see, that was 11,180. But what we finally executed, this is 17,773. And in this you see that we follow the minimum sample given by the Pakistan Bureau of Statistics. But in some areas we cover more patients to have more validity of the survey. This raises a question of validity of that survey. So how we resolve this issue? Now when we are going to publish the final data, we will try to get the weighted prevalences. And this is a concept that I am going to show you, that how we get the weighted prevalence which resolve this issue or inequality in the data that we have collected. So for example, the age group of the participant, majority of the age group was 2/3 of these patients were below 30 years. And if you see that more than 2/3 patient, they were below 40 years, 1/3 below 30 years and 2/3 were below 40 years. And gender distribution was just reflecting our population, source population from which this data have been driven. And this urban-rural ratio is also reflecting the source population. That is 63.8% from the rural area and 36.2% from the urban population. The marital status, 3/4 of the population participants were basically married. And prevalence of mood disorder, if you see, that was lifetime prevalence was 18.1% and current was 11.3%. Now we calculated the weighted because of the disparity. Now the weighted comes out to be the 17.8%. So this is the final, that is basically we have calculated. And the weighted current is 10.16. And in a similar way, the weighted manic is 4.4 and 4.2. But here I would like to share, just to show you the difference between the urban and rural population. If you see that 18.1% that I showed you in last slide, unweighted, you see that the prevalence of this depressive disorder is more in rural area as compared to the urban area. And the same exists true for many other disorders. If you see even the manic disorder, this is the same is true. And the prevalence for the anxiety disorder is shown, and Adjacent to this is weighted lifetime and current prevalence of this disorder. When we are going to publish the data, basically we are going to publish these weighted prevalences because these are the viral prevalences that we are going to share. So I'm just speaking because the shortage of the time, you see these are the different prevalences that, and we are going to, very soon we are going to have a program and we are going to publish a monograph in which we are going to share these, all these figures and going to share all these figures with you. So this is very important, and that important message which I would like to share with you, that about providing this evidence-based data, this survey will help in ensuring that everyone have access to the quality mental health services, so the stakeholders can be convinced for designing policy and allocation. But in the last, I have tried to finish it within 5 to less than 10 minutes. But before that, because I was not sure, I want to share this data again of WHO site which is available, which is showing that the female urban is 25% and rural is 72%. What does that mean? 3/4 of the population of the Pakistani rural area is basically suffering from psychiatric disease. And in this survey, we don't find this. And you see that difference between, although there is more, it's slight different, but difference is not very much in rural and urban area. And one of the reason I believe is that there is no difference in the dynamics of the people living in a rural area and the people living in the urban area. I used to see the slum areas of the Karachi. If you're going to see the people living standard is all the same. They have all those deficiencies which initially I have mentioned for the rural area. The same can be applied that. So this is one thing which is, differing from, which is basically contradicting the previous studies. But finally, I was not sharing it because I have some work to do on it. This is just, in last moment I got these results. So this is just to share because the Haresh request, and I believe that he is saying, and looking at the interest of the people, this is the thing that I would like to share. And thank you very much. And I think based on Dr. Asad Tamizuddin is going to talk about infrastructure and the service provision in that cases.